Good afternoon and welcome, everyone. My name is Sierra Lamonaco, and I am the Alumni Relations Officer with the Faculty of Applied Science and Engineering, as well as the program lead for the School Lunch and Learn series. I would like to thank all of you for tuning in today for our last School Lunch and Learn presentation of the 2024-2025 season. Now, we have alumni tuning in from all over the world. We have guests joining us from 13 different countries, including Brazil, Canada, China, Germany, Hong Kong, India, Indonesia, Jamaica, Netherlands, Philippines, Singapore, Taiwan, and the United States. Now, before we start today's presentation, I wish to acknowledge the land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous peoples from across Turtle Island, and we are so grateful to have the opportunity to work on this land. Now, you're probably wondering, why is today's presentation extra special? Well, because we are gathering during Black History Month, a time to honor the groundbreaking contributions of our Black scholars, innovators, and leaders who have shaped history and continue to redefine the future. It's also a moment to stop, reflect, and recognize the persistent inequities that demand our attention and our action. And today, we have the privilege of hearing from Dr. Enid Montague, a trailblazer at the intersection of engineering, technology, and healthcare equity. And as the director of the Black Research Network, she leads a transformative community that amplifies Black research excellence. Dr. Montague is pioneering AI-driven solutions that streamline healthcare delivery, reducing administrative burdens, improving access, and addressing the disparities that disproportionately affect marginalized communities. So you see, Black History Month isn't just about reflection. It's about recognizing and celebrating the brilliance, and innovation that continues to push boundaries and shape a better future. And Dr. Montague's work is a testament to that legacy. And as a Black woman leading transformation and transformative research in a field that shapes the future of healthcare for everyone, she exemplifies how diverse perspectives and expertise are the drivers of innovation. And through her research, advocacy, and bold new ideas, she's paving the way for a more equitable and inclusive world. That being said, Professor Montague is also this year's U of T's Engineering Ambassador for U of T's Giving Day campaign, helping us to build a stronger, more equitable, and compassionate U of T engineering community. So from February 26th to March 26th, all of these donations that are to our featured funds will be matched dollar to dollar up to $1,000 per donation while matching funds last, and will help to continue with our faculties as they continue to strive for inclusive excellence. Now, as we wrap up an incredible year of School Lunch and Learn events, it is my great honor to introduce someone who has been the heart of this program's success, Lori Hevola. Lori is a distinguished 65 electrical engineering graduate, a visionary leader, and someone whose deep commitment to U of T has shaped this series and our community in profound ways. And for over a decade, Lori has dedicated his time, his expertise, and resources to serving as the chair of the School Lunch and Learn program. His tireless efforts, not just as a donor, but as a true champion of knowledge sharing, have created an environment where our community continues to thrive. His leadership and generosity have made a lasting impact on this program, and we're so grateful to have him. And with that, please join me in welcoming Lori Hevola, who will now formally introduce today's guest speaker. Thank you.
Thank you, Sarah, for your very kind introduction again. It is my pleasure to welcome our guest speaker, Professor Enid Montague. Dr. Montague is a Canada Research Chair in Human-Centered Automation and also an Associate Professor in the Department of Mechanical and Industrial Engineering. Dr. Montague researches appropriate automation between physicians, patients, and technologies, and designing systems for health equity and patient safety. She uses mixed methods in naturalistic settings to model human-technology interaction and develop guidelines for human automation that is efficient, effective, and safe for patients and healthcare providers. She serves as the director of the Black Research Network and director of the Wellness and Health Enhancement Engineering Laboratory, otherwise known as WHEEL. She has received numerous awards for her research, including the Francis Research Fellowship, an early career award from the National Institutes of Health, and a Fulbright Award to improve healthcare systems. And now, without further ado, please join me in welcoming our guest speaker, Professor Enid Montague.
Hi, everyone. Thank you so much for that wonderful introduction. I'm so happy to be here. So I'm going to talk about automation and healthcare for everyone, everywhere. But I'll start by just giving you an overview of my discipline. So I'm a human factors and ergonomics engineer. And what we do is we understand people, groups, and systems, their capabilities, limitations, and behaviors, and then we apply that knowledge to the design of systems. And systems can include technologies, tools, jobs, tasks, environments, and processes. And we try to optimize that application for improved system outcomes. So we want to make systems more efficient, more effective, safer, more comfortable, and increase human satisfaction. And the goal ultimately of human factors engineering is to design the systems for the people that are in those systems. So to make sure that the people have safer outcomes or be more efficient with their work and more comfortable. When I started in human factors and ergonomics engineering, I was actually interested in ground transportation, so automotive engineering. And one of my first research projects was the 100 Cars project in DC. So what they did is that they gave 100 people in the Washington, D.C. area a car to drive for a year. And this was an instrumented vehicle that recorded everything that the person did, and there were small cameras inside as well. And so my job was to try to understand what makes people crash. And so I had to sort through lots and lots of video to figure out what happened before and after crashes that led to people driving. And this was a really exciting project, but it really exemplified the complexity of an error within a complex system. And as you can imagine, there are all kinds of reasons that people crash. And I was really excited with this work, really understanding human behavior. But then I started to learn about this report that came out from the National Academy of Engineering and Institute of Medicine. And what it said was that there were lots of problems in the healthcare system and that we needed to design a better delivery system. And one of the challenges that they mentioned was that there was a lack of engineering and computer scientists working in healthcare. So the system had largely been developed without a lot of guidelines, and that there were a need to have engineers work in this area. And I found this to be really inspiring. I found that I really was excited about the idea of the complexity in healthcare systems that involve patients and humans and many different doctors and procedures and medications. And so this really inspired the work that I'm going to talk about today. And so most of my work is in the area of primary care. And so if you're not aware, primary care is the foundation of our healthcare system. It's the first point of access for healthcare for most people. It supports people at every stage of life, from birth till the end. They provide comprehensive care that promotes health and well-being. And when you think about it, the primary care doctor is, the idea is that you have this one doctor that knows you, everything about you. They connect you to specialists when they need it and other resources. They're the first person that wants to help you with transitioning to other stages of life, like when you're going to have children or you're getting older. They're the first people that will notice signs and symptoms of chronic conditions like diabetes and cancer. And then they also help you through the treatment of that as well. So they help you in preventing, identifying, and treating illnesses. And they're your hub for the entire healthcare system. And this is across the world. So in Canada, 1 in 5 Canadians, about 6.5 million people, don't have a family physician or nurse practitioner they see regularly. So they don't have a primary care system. And what you can see within this first graph here is that we have the most physicians in Canada than we've ever had before. Yet, in the second graph, we're below the average in OECD countries. And so these are the countries across the world that have similar economies and democracies. And we're not alone there. So Canada has a low physician to population ratio, along with other countries like the United States, the United Kingdom, and Japan. So this is a problem for many places. Like, how do we provide primary care to everyone without the number of physicians? And this problem is even more pronounced when you look at the global south, where you see that many areas are operating without enough doctors, nurses, and midwives to support the population. And that the World Health Organization says that there's a global shortage of about 4.3 million doctors and nurses, which is about 15% of the total nurses worldwide. So 57 low-income countries are facing a severe crisis that they just don't have the human resources net to meet the minimum needs of healthcare. And this is becoming worse and worse. And so some of the reasons that we don't have as many primary care physicians as we need is one, many primary care physicians are getting older. So we have this older aging population of people, which means we have more people that need care, but also doctors are retiring and fewer people are going into primary care as well. And we also are starting to see that people are leaving primary care at greater amounts than in other physician specialties. So what we have now is that we don't have enough care providers. We have increased volume of patients. We have more complex patients as people get older and they live through many different chronic conditions. We're doing a good job of caring for them, but we're also seeing increases in chronic conditions. So we have more complex patients, which means that we need a healthcare system that can help us do more with less, some new designs. And so how do we use automation to increase capacity? And so when I started looking at this challenge, I took an engineering design approach to this. And one of the things that you have to do is to understand, like, what are the needs? What do the people need? What are the gaps? And the Agency for Healthcare Research and Quality actually published a call there, and they said there's actually very little research that has been conducted to understand what clinicians actually do, what is their cognitive workflow, what are the tasks they perform, who does it, how it could be performed with or without technology. So there just wasn't enough information about how doctors work and what would be the impact of different changes in their behavior on the outcomes. And so understanding the clinical needs, then we need to translate that into this balance of social and technical requirements to create these innovative designs. And so I started off with conducting a study to understand how physicians interacted with their patients and how their behaviors might influence patient behavior. And I was really interested in physician attention. So if we could understand, like, where they pay attention, maybe that could help us understand the impact on patients. And this study was really cool because it was a randomized controlled trial. So we recorded physicians with their patients, and they didn't have electronic health records, and they were all patients being seen for the same thing. So there were about 272 visits. And then in one condition, we had the physicians behave normally with their patients, and we recorded them. And then another condition, we had them work with an acting coach to enhance their behavior so they could behave as, like, the best possible doctor that they could, which also influenced their attention. And so we had these two conditions with two different types of videos, and then we coded these videos at a micro level to see where physicians and patients were looking, how much they touched their patient, how much they spent interacting with the record, to give us an understanding of how they interacted and communicated over the course of this visit. And so we found, one of the things that we found here was that eye contact, which we called mutual gaze, increased quite a bit during the enhanced encounters. And that was for all phases of the encounter with the patient, which we were surprised. We thought, of course, people will maybe make more eye contact during like the pre-exam and post-exam, but like during the exam, maybe not. But during the entire time, there was an increase in eye contact. And we also noticed that for the enhanced encounters, patient outcomes were different. So they reported being more connected to their physician. They liked them more. They had higher trust scores. They were more likely to adhere to medical advice as well. And when the physicians were not in the enhanced encounter, they made less eye contact with the patient, which meant the patient also didn't make eye contact back. So it's kind of like when you're in a good conversation and you speak and they speak and you get into a really great rhythm. That's what happened in the enhanced encounters. And the non-enhanced encounters, the physicians were fine. They but patients tended to lose attention. So if the physician wasn't paying attention to them, they didn't quite know where to look. So they would look in the corner and they'd look, in other parts of the room, and they really were less focused, which could influence some outcomes. So we wanted to try to see if we could build models of these types of interactions to help us predict outcomes. And we use these approaches called these dynamic nonlinear sequential models. And these came out of a researcher named John Gottman. He wrote this book called The Mathematics of Marriage. And maybe you've heard of him. He's pretty popular in helping people fix their relationships. And so what Gottman did is he would bring couples into his lab and he would have them argue. And then he would look at the influence of one partner on the other and build these models that could help predict not just like if a couple was going to make it, like were they going to stay married, but like when they would actually get divorced. So he had a group of people who were going to split up within a year, a 5-year, and then like a 15-year period based off of these types of interactions. And so we use these sequential models to help describe the clinical interactions, predict outcomes, but also to give us guidelines for how we could think about designing new technologies to support the clinical visit. And so around this time, electronic health records were becoming more and more prevalent. And so before this, healthcare, like all records were primarily paper. And so when the physician saw a patient, they would write on the paper record. And this was problematic for a lot of reasons. And so in the US, particularly in the South, like after like Hurricane Katrina, everyone's records were completely lost. There was no record at all because it was all on paper. So for natural disasters. And so Canada invested about $10 billion to get physicians onto electronic health record systems to increase accessibility of data, better coordination of care, reduce handwriting errors, and then ideally provide patients with better access to data. I said sometimes because you don't always get that data. And so we wanted to see like what was the impact of electronic health records on patient and system outcomes. And we used a similar approach where we video recorded visits with patients and their physicians. We had multiple cameras, so different angles of cameras in the room, so close up so we could see facial expressions, wide angles as well. And then we wanted to spend a lot of time to see like how much attention was taken from using the electronic health records, or was there an impact at all? And so one of the things that came out of this was that there were these 3 interactive styles, which was a more technology-centered style, one where they would move back and forth, and then a human-centered style, where they focus mostly on the patient. And in the technology-centered style, we found that the clinicians spent almost 50% of the visit looking at the screen and about 20% typing. And so these are, these are like 10 to 15-minute visits. Sometimes this is like people get 1 or 2 of these a year. They have to describe, what's going on with them to their primary care doctor. And we know that cognitively people aren't great at multitasking. So, when you're typing or looking for information, information that's coming in from the patient isn't going to be coming in the best way. You may miss pieces of the information while you're trying to type. We all think that we can multitask, but we actually aren't great at it. And so what happened with the electronic health records is that we started to see that this new technology had impacts on quality. So physicians were spending more time doing charting, so that now that they had to put information into the database, they had to look for information, they had to put it in there. They made new errors that they hadn't made before. So this, like trying to remember or missing information that the patient was saying, or trying to multitask led to some new errors. So there were some challenges with effectiveness, but handwriting errors were reduced. And so now we had a clear record of what was happening that could be shared with other people. Patient-centeredness was affected, so physicians focused more on the EHR than they did on the patient, which meant that the patients, again, tended to be less engaged, and that led to some challenges with adherence. And then there were more errors as well. So what happens when you're trying to put information into this database, and it's now a new part of your job, that it can create time pressures. And so if you can't get to it at the end of the day and you're not allowed to put something on written records, that means that you have to remember everything that the patient said to put it into the record. And so if you're trying to remember by the end of the day, you might miss some information. And if you're really behind and you're waiting to the end of the week to do this, you might miss even more information, which can lead to diagnostic errors and misinformation from the patient. So there's pros and cons with this, and around this time we were starting to also look at minority serving clinics, and so we wanted to see what were work conditions across a variety of clinics in the United States. And one of the things that we started to see was that the minority serving clinics in the U.S. were the federally qualified healthcare system, so they're similar to the community health center clinics that we have here in Canada. And these are great clinics. These are some of the best doctors that you'll ever meet. They often speak multiple languages. They live and serve in communities. And so they really are that community doctor. But we were finding that they were having high levels of turnover. And despite working a lot, they were having challenges with quality and errors because they were not really receiving like the same work conditions as other clinics. They didn't have the same access to clinical resources. And so it was leading to early signs of burnout. And the years after that, we started to see major signs of burnout throughout the clinicians that we were observing in our studies. And so now Canadian physicians spend almost one extra working day, 10 hours a week on administrative tasks. So it's a new job. It's not the same job as our first studies where they didn't have the electronic records. And then burned out doctors are, when they become burned out, they decrease their workload. So they see fewer patients, they retire early, and that leaves the sustainability of the healthcare system at risk. And we started to see this in the minority serving clinics first, but now we're seeing it everywhere. So right now, it's estimated that, 2/3 of Canadian physicians feel like their workload is too demanding. They have symptoms of burnout. And the drivers of burnout are excessive workload, inefficient work environments, problems with work-life balance, loss of autonomy, flexibility, and control in their work, loss of values and the meaning of work, and inefficient technology implementation. And a lot of times when we talk to primary care doctors, they love their jobs. And people go into these positions because they want to connect with patients. They want to connect with communities. And so when you feel like you can't do that, you lose value and meaning in your work because you're overworked and you can't have those connections. And so burnout has a lot of serious consequences. So burnout can lead to medical errors, impaired professionalism, reduced patient satisfaction, turnover, depression, suicide, accidents, and also bias as well. Because as your brain is trying to overcompensate, you start to rely on heuristics to make decisions instead of being able to use like the full breadth of your cognition. And then this was an article that was in the paper a few months ago that was about a physician in Corner Brook who was quitting their practice because they were burned out. They just couldn't keep up with the workload. They felt extremely guilty because they had so many administrative duties and they couldn't find anyone to take over. And so now there's a community that has no physician at all. And so this is the story that we're having right now. And so what's the solution? So automation or replacing human work with digital tools or AI, is an attractive solution to providing primary care to more people. And what might this look like? And so when we think about automation, we tend to think about them in levels in industrial engineering. So level one automation would be things like basic tools that can help with administrative tasks. So like this electronic health record, helping physicians with record keeping, documentation, maintaining accurate records, completing paperwork for insurance, legal purposes, all the way to level 5, which would be a fully autonomous tool. We can also think about automation for patients within this. So for example, an example here might be patients identifying a need for care. Maybe they're using a chatbot triage. So there's no human involved with this. The tool has the capability to make the clinical decisions independently, to make a diagnosis or treatment without human intervention. The patient might use a tool like this to decide whether or not they should seek primary care or urgent care or a specialist based off of symptoms that they might have. And as we mentioned before, there can be challenges with even low-level automation. So our approach to expanding access to primary care revolves on 3 different aspects. So one, improving MD or physician work and saving time. So if we can reduce the time physicians spend on administrative tasks, it can allow them to see more patients. And this might be a more effective intervention than some of the other tools that we have. 2, we want to support patient self-monitoring treatment with computerized tools. So allowing patients to track their own health and receive appropriate treatments on their own terms can reduce burdens on the healthcare system. And then 3, diversifying the role of the physician to provide quality, equitable, but remote care. So leveraging remote monitoring systems and supporting clinicians in transitioning to other types of ways of providing care. And so I'll give you some examples of some ways that we're doing this. So one of our projects right now is about helping physicians, improving physician work and saving time with AI. And so I mentioned that administrative burden is a huge problem right now with the implementation of new electronic systems. And so we've been evaluating digital scribe tools. So these are tools that leverage natural language processing, AI, and speech recognition to record the clinical encounter and generate the structured clinical note for the physician. So instead of the physician having to type in their chart and remembering what they said, this AI tool is recording that and creating the chart for them. And so we conducted a simulation study with 9 primary care providers in Toronto to see if the use of an AI scribe actually saved them time. And we found that it led to a 69% reduction in time spent on documentation overall, which is huge. And so if you think that if we're giving physicians, 10 hours back per week, and each visit is about 10 minutes each, that's how many more patients that they're able to see. And so we can continue to study physician work and look for opportunities to save them time and reduce burden. It can allow them to see more patients, which can put a huge dent in the shortage of primary care physicians. Outside of that, it also improves the quality of work for the physician. So reducing this stressful administrative task can also allow them to spend more time with their family instead of doing charting on the weekends, which can alleviate burnout and create happier physicians that are able to stay and practice for longer amounts of time. And so we've been studying the use of AI tools, but also looking at other aspects of clinical work like the referral process and how we could use AI to improve the quality of physician work and save time. The second thing that we've been working on is really looking at self-monitoring for patients. And allowing patients to identify symptoms of concern, and thinking of ways that AI and automation can help provide fill gaps in care. And we've done a lot of these. So like the first one, I can't share some of the ones that we've commercialized yet, but we've developed an application for lactation support. And so you can imagine like when patients are having challenges with lactation, when they have a new baby and they might need some additional support, it can be really challenging if they have to go back to their primary care doctor to ask questions or keep track of like the weight of the baby or things like that to see if there are problems. And so systems like this can allow patients to identify symptoms of concern like low birth weight, low milk production, but also provide education to help support them at the moment of need, whether it's 3 a.m. or or in the middle of the day when they're trying to get an appointment. We've built a lot of self-guided treatment supports for mental health. So like this CBT application, this cognitive behavioral therapy that allows people to track symptoms that they might have related to their mental health and self-guide them into tools that can help them with seeking treatment for symptoms of depression or anxiety. And these tools can be really helpful as well as a gap if you have low level symptoms and might not need to see a physician right away or between visits. We've also developed some integrated systems that allow patients to self-monitor in treatment and connect with their physician in more meaningful ways. So the one on the bottom is the MedLink system. And so this is for patients who have depression. And so one of the things that happens when you're diagnosed with depression, often it's with your primary care doctor, and your primary care doctor will prescribe some medication. And so that process of figuring out how to get medication can be really tricky for people, especially for people with depression. It takes several weeks for it to start to work for you to feel better. And so with the system like this, first, the pill bottle allows you to, it lets you know when you haven't taken the pill. So it gives you an alert to remind you, which is one of the symptoms of depression can be like trouble remembering things. And then also, if you don't take the pill, it may say, well, why are you not taking it? And so maybe you're not taking it because you don't like certain side effects or you don't feel like it's working. And then it can kind of coach you along to help you to continue to take it. And remind you that like, oh, you may have some side effects. These are mild side effects. They'll go away in a few weeks. Try to persist through it because you'll start to feel better in 3 weeks. Or it might say, these are pretty serious side effects. You need to go back to your doctor and maybe be prescribed something new. It tracks your current depression level so that you can see that you might actually be feeling better over time without realizing it, to give you the positive reinforcement to continue on. And these types of systems can help reduce medical error and treatment errors, but also fill in some of the gaps in terms of treatment that cause people to kind of have to come back into the system after a visit, to fill in the space where you might have multiple interactions with a physician that you could self-monitor and treat. And the third thing that I had mentioned was diversifying clinician work to provide quality and equitable care remotely. And so in this studies are really looking at how can we move from one-on-one interactions with patients and physicians and other care providers to systems where we can monitor potentially hundreds of patients remotely. And also like thinking about how we can remotely monitor patient symptoms to identify distressed patients sooner. And so this image on the left here, this is a virtual intensive care unit. And so one of the things that happens in a virtual intensive care unit, it looks, kind of like an office. And so a nurse who may be, tired of working on the floor, the nursing can be physically demanding. My mom's a nurse, and so I understand that over time it can be physically demanding, being on your feet, working with patients, moving patients over time. And some nurses retire early because of that, but they still have something that they could offer. And so in this system, this is a nurse that's remotely, maybe not even in the same city, who's able to electronically monitor vital signs and video of patients who are in the ICU, report any downward trends, and then also act as an additional resource for novice nurses. So someone who's a senior person who can communicate with the nurses on the floor to provide remote mentoring and guidance and identification of patients who may not be doing well in those settings. So giving that extra set of eyes. And you can see where this can be expanded to multiple people working together in a remote setting that allows them to provide care, more people to can provide care in places that they might live in under-resourced settings. And so virtual ICUs and virtual remote monitoring can occur in any place and can be one way of diversifying clinician work to provide more care to more people. And we can even look at remote patient monitoring like outside of hospital settings, but even in home settings. So looking at something like a dashboard where patients have devices that they can record their symptoms and well-being, or blood pressure, or pulse oximeter, or weight over time, that gives a dashboard for physicians who may be remote to be able to provide remote monitoring and care. And there's lots of benefits of remote monitoring. So it can improve patient access to care, particularly people who live in rural or underserved areas. They can receive continuous monitoring without frequent in-person visits. I've lived in a remote setting. And so where I lived, it was, I think it was 2.5 hours away from the nearest hospital, and we were on top of a mountain, and there was no public transportation. And if it snowed, the roads weren't necessarily going to be cleared right away. And so the decision, to go to a hospital or something was a big decision. It was hard to get to some of the doctors and clinics from that place. And so remote monitoring can provide continuous access to people who live in underserved areas. And even other countries, you can provide remote monitoring for people who live in countries that aren't Canada, from Canada. Remote monitoring can provide early detection of health issues. So this continuous data collection can help us detect problems early. And it can save costs. So it can reduce the burden on healthcare facilities by minimizing emergency visits and inpatient care, by being able to intervene when it's appropriate, and allowing to have the amount of data that you need to decide when you need to have an emergency visit, or if you can share that data with another type of doctor to prevent things from getting worse early. But there's still a lot of challenges with remote monitoring, and we've been working on some of these. The reliability and accuracy of the devices can be really challenging. They can lead to inaccurate readings or data loss, but this is one of the benefits of continuously collecting a lot of this information. And the data that comes from them can actually add to healthcare provider workflows. So having a lot of data can overwhelm providers. And this is where there's a real opportunity to think about how we can integrate this amount of data into good interfaces and allow AI to help summarize the data so that it's in a usable format. Many providers don't like to use some of these systems because it's just too much data for them to process. And then, of course, there are lots of equity and accessibility issues with using some of these tools. Patients with limited internet access or financial resources may have difficulty using remote patient monitoring tools. And these are some things that we need to continuously address when thinking about this. And so, the question is, can we achieve safe access to primary care to everyone without automation? And the answer is probably not. We already have the most physicians we've ever had and the most patients in need. And so we will have to think about some changes. And I think that we can re-envision healthcare work, understanding how we can reduce administrative burden to allow patients to see more patients, or physicians to see more patients, may be more effective than adding new technology. So thinking about how to design the best technologies to make work life beneficial for physicians and for patient outcomes is a really important part of re-envisioning our healthcare work. We need to understand how patients from different backgrounds work as well. We have a tendency to put additional workload on patients and then blame them when it fails. And so continuing to think about what are the things that patients need and taking a stepped care approach. And that means that technology is not going to work for everyone, but for the people that it will work for, that's the first point. For people who need maybe a more remote monitoring approach, we can add that. And for people who really need, intensive face-to-face approaches or team-based approaches, we need to be able to provide those for the people that need that. We need to continue to address digital infrastructures and inequities. And one thing that's really challenging is that the systems that we have in place for primary care are not interconnected. So we don't really have like an interconnected health information exchange or interoperability. The vision of electronic health records where your data would be accessible everywhere is really not the case. In many places, people are still using fax machines to transmit information and data. And so addressing these inequities and the infrastructure will allow us to be able to adopt automation more easily and will allow us to be able to provide care and access to more patients. And with this, we also need to think about digital literacy, technology access, and data access as well. In the rural environment that I mentioned, like we don't always have Wi-Fi access in those communities, but even in cities like Chicago, where I moved from, there are pockets of the cities that don't have reliable access to internet and data. And so these are things that need to be addressed. If we're going to provide digital first healthcare for patients, we need to make sure that all people in our community have access to the digital infrastructures for those digital tools to be able to access them. Otherwise, we'll just create more divides and inequity. We need to evaluate our automation continuously and equitably. We have to continuously evaluate the usability, the impact, and the risks of automation before implementation. And one thing, it's important to note is that there's 400,000 health and wellness applications out there. And so when I talk about like using self-monitoring tools, like it still can be, most of them are not well validated, well integrated into patients' lives. And so we have to really think about how do we evaluate these to provide the best tools for patients and physicians and make sure that we're making informed decisions before we implement low level and even high level automation, because the outcomes can be pretty problematic. And I also think engaging the most vulnerable communities first is a good approach for thinking about automation, designing at the margins, taking a look at the people who have the lowest level of access, like that clinic that I showed the article about, where a single physician is so burned out that they have to shut their doors, and now there's no primary care physician for that area. Really thinking about what a community like that would need to be able to have to provide more access to primary care would be a good place to start, because what works for the most vulnerable communities usually works for everyone. And so with that, I want to thank the people who funded this work, a variety of different agencies, from engineering and health agencies, including some Department of Defense funding from the Air Force and Women's College Hospital, and the Chicago Health Information Technology Regional Extension Center as well. And I want to say thank you. If you want any information about publications, the resulting from this project, or have additional questions, thank you very much.
Thank you. We've reached the top of the hour, so now I would like to provide my closing remarks. Before we close, I would like to thank Professor Enid Montague for being with us today and for providing an excellent presentation. We had a huge turnout online. Historically, School Lunch and Learn events are hosted on the second Wednesday of each month, beginning from October of each year to February of the following year. Today's presentation is, of course, the final event of the 24-25 School Lunch and Learn season. However, we look forward to resuming the new season yet again in October of 2025. In closing, I would like to thank all of you for joining us for today's presentation, and I hereby adjourn the last presentation of this year's School Lunch and Learn season. It was a pleasure being with all of you for School Lunch and Learn, and we look forward to reconnecting with you in October of this year. Thank you and have a good day.